Good morning, everyone. Welcome to VNU Health. We have a great guest in the studio. He's actually just up the road from us from beautiful Fort Lauderdale. He is up in Vero Beach, Dr. Hugo Davila. Welcome. Welcome to the
Thank you,
program.
Robert. Thank you for this kind invitation. I really enjoy talking to you and especially talking about female pelvic problems is always a pleasure.
Well, we appreciate you taking a little bit of time before you start your clinic on this beautiful Friday. And it's really interesting. So, me doing some, I always like checking up, seeing where you've been, what you've been up to. Great LinkedIn profile, and I love the fact of what your what your goal in your practice and what you think about your professional standpoint and is to improve patient care with empathy, compassion, research, and technology. And I think we'll kind of touch on some of those things today because a lot of things are happening in women's health, right? That's the technology side of things, and you're always a great source of the what's new in the world of technology. And so, if you think about let's just say maybe the last 5 years or so, where do you feel some of the technology for women's health has progressed in? Because I think maybe when you started and when I started in this space, they didn't have a lot of options out there. But now they continue to have more options, and I know you have. You think about your practice and some of the equipment that you have. What are some of the things that you've invested in that would help women that are dealing with these pelvic health issues?
That's a great question. So, in the pelvic floor field, we'll see a great gaps. What I mean about that is you see areas in the pelvic floor disorders that are a lot of technology in, and then you have in other areas that are completely neglected and nobody has put anything on that. And I'm going to try to touch on both because, as a surgeon of the pelvic floor, I struggle sometimes with that. So starting with the question that you asked me about the technology, I think that one of the most exciting things that I see in and a lot of technology and companies are putting efforts into this is the ultrasound imaging, MRI office imaging, so 3D reconstruction,
Mm-hmm.
you know, enhanced ultrasound, artificial intelligence, evaluating the ultrasound imaging and giving us feedback. So I think that imaging in general is going to allow us as a pelvic floor surgeon to become more precise
Mm-hmm.
in making the diagnosis, in providing answer to the symptoms of our patients. Okay, um, I think that these imaging, the analogy that I always give is, if you are a heart surgeon, so you are a cardiothoracic surgeon, you work in one organ, but that one organ has four chambers. If you are a pelvic floor surgeon, you work in one place with four organs. Okay, so the pelvic floor is such a complex environment that you cannot handle the pelvic floor only with one training. So you need to be a urologist, you need colorectal surgeons, you need gynecologists, you need urogynecologists, and you need a multidisciplinary team to take care of the pelvic floor. That is telling you how difficult it is to deal with this. And if that is true, then it is impossible for us to think that I'm going to be able to tell my patients all the answers just by doing a pelvic exam.
Right.
So I'm going to need something else to provide and to add a little more information to the pelvic exam. And I think that is the imaging technology leading by ultrasound. Now we are getting the office MRI. I'm extremely excited about that. And this office MRI is going to provide a pelvic evaluation for us as well. So I think it's just the beginning, okay? And then
So I've been
on the other
so
side,
I want to pause there because I've had the fortune to be in the operating with you, and I think we were you had a urethral diverticulum, but you also brought in the equipment, right? So you had the imaging equipment with you as part of that surgical approach. So what were you in that scenario? What were you looking for, or why did you want to have that equipment in the operating room with you that
right?
particular day?
Couple of things is, the way I see the ultrasound is the ultrasound in the office and the ultrasound in the OR, in the operating room. Okay, so the application and the use a little bit different. Okay, so for that patient that we did together, so that patient was a 55 years old female that was referred to my practice with a history of infections, UTI. Okay, Dr. Davila, this patient is having multiple UTI, and beside that, she has a cystocele, a prolapse bladder. And then please, evaluate this patient. So of course, I do the pelvic exam, and it looks like the patient has a cystocele. I'm wondering if, maybe she's not emptying the bladder well. Immediately get my ultrasound, and when I'm doing the ultrasound, I see something in the distal urethra
Mm-hmm.
that looked like a diverticulum. So right there, I immediately change, my mindset and say, okay, this is maybe a diverticulum. I did a endovaginal ultrasound with a 3D reconstruction that we do in my practice.
Yep.
And I was able to see everything about that diverticulum connected to the urethra, how big it was, where was the sphincter. So right there with that 3D reconstruction, I immediately start thinking about my surgical step.
Right.
And then when I take the ultrasound reconstruction to the OR, then I'm doing the incision based on what the ultrasound is telling me. Okay, this diverticulum is a little more to the left. So I know that I need to make my incision a little more to the left. Then if I see the connection between the diverticulum and the urethra, then I know I can measure the distance and I know where to go and how far behind I have to go. So I make sure that I don't get into the sphincter and injure the sphincter, and then the patient maybe become incontinent.
Right.
So
So let's
so
pause there for
use
a second because we've got uh, diverticulum. How would you explain that to the ladies of what that medical condition is?
correct. A diverticulum is a problem. It doesn't happen that frequently. Incident is between in the United States, I will say between 5 to 8%. It happen more in developing country for trauma or injury during vaginal birth and stuff like that. But this is a little like a tick, like a polyps, okay, that connect to the urethra, and then by connecting sometime to the urethra, collect urine in that pocket.
Mm-hmm.
And therefore the patient have three symptoms that you have to be aware: infections, leaking, incontinence, and pain during intercourse. They tell me, Dr. Davila, during intercourse, I have pain, I'm leaking, I have infection, I'm burning sometimes. So when they tell me that, I immediately think about, is this patient possible may have a diverticulum? Okay, it's just a pocket that connect to the urethra that collect urine there, and sometimes even you can, because that urine stay there, you can even develop stones in that diverticulum.
Right.
So, but it's not that common. But again, when you find that, then you're gonna fix all the symptoms
Right.
and with the surgery. So as a surgeon, I really create a positive outcome for my patient by doing the diagnosis about the diverticulum.
Right. And being very precise about how to approach it. Right. That you already recognize it in your office because of your technology, and then you say, okay, I'm going to take this technology to the operating room because that's going to allow me the best chance so that I don't have to I take a very sniper approach to it instead of a shotgun. Like, I'm not going to open everything up. I want to know exactly where to make that incision and
Correct. So
where to
once
address it.
we take the ultrasound to this operating room, then that ultrasound with the 3D I think the key there is the 3D reconstruction. It's like as you saw in the OR, it's like a little cube that I can rotate. I can go from above down to the side to the middle. So the key there as a surgeon is a 3D reconstruction that allow me to see where to make the incision, how far I need to do the incision to the back, to the side, and in that way I can take the whole diverticulum intact.
Right.
And then once I I take the diverticulum out, then we have to use the graph that we used to that day with you, and we have to create not only close the connection to the urethra, but to prevent that that suture there to open again and create another diverticulum, we put a graft that reinforced that suturing layer that we did,
Right.
and the patient recovered quite well, and she's doing excellent. So
Love that.
is a reconstructive surgery that required a lot of understanding of the pelvic floor, and certainly you need a lot of resources, not only the practice, the imaging, the understanding, but as well you need to know how to handle graft, reconstruction, closing urethra, and that's the reason why it's so challenging to work in the pelvic floor. And I think that is the exciting part to be a surgeon in the pelvic floor.
No, absolutely. So you've got some equipment coming, you had said? So you've got an
Yeah,
MRI that's
so we're gonna get an MRI, an office MRI, but this is a small MRI. It's a Tesla 0.7, and this MRI has been approved to do prostate MRIs and focal therapy, but we are creating some IRB approved protocol to expand these to the use of the female pelvic floor. And the good thing about the, the office MRI is it doesn't require all the infrastructure. The patient is in the office. So remember that the key in any pelvic floor imaging is that we can ask the patient to push, to squeeze. So
right.
I need to see how the pelvic floor behave in different state,
Sure.
and so having that in the office is very important. And so I'm looking forward to start seeing and comparing the MRI with the ultrasound. Another thing that we are looking forward to, and we're already using, and we're sending a paper to the Journal of Urology, is elastography. Basically, it's a color, it's an ultrasound that gives us color, and we can see the scar tissue. Just all for all your all the patients and all the women that are listening to this, one of the main reasons, 40% of patients that has vaginal birth, they ended up later on in life having a vaginal prolapse, meaning the bladder drop, the rectum drop. And why is that? Why 40% after vaginal birth have a prolapse? Well, so when the head of the baby is going through the vaginal canal, it's inducing a 10 centimeters, more or less, a stretch of that. And when you induce that stretch, you start, inducing injuries to muscles, fibrosis, and affecting some of the, ligaments as well. But then you heal, okay? And the healing process, you're 20, 25, 30, you don't see that much of a problem. But when you become 60, 65, that injury and that scar become the point of weakness,
Right.
okay? And then you have a prolapse. So with this new technology that we have, which is called elastography, I can see that in color. So red will be a really bad scar, so it give you a color red, and blue, no scar, excellent support. So we have seen that very exciting outcomes there. So, and then another thing that we're trying to incorporate as well into our practice is to increase the megahertz of the ultrasound. So as you know, I use the 14 megahertz. So that is just to explain to the patients and the women that are listening to us, megahertz in ultrasound is like the quality of the TV. So the higher the number, the better the quality, so I can see better. So we're trying to get a 29 megahertz ultrasound to see if we can see a little more in detail the pelvic floor. So we are putting a lot of, research in trying to find out what this imaging technology can mean for our patients in the pelvic floor.
So if you think about the before and afters, right? So that once you have an idea of where the scar tissue is, where the weak points are, then you can go ahead and address them surgically, right? So how does that then help you uh, make a more informed approach to, say, taking the woman back to the operating room?
Correct. So, so once you, first of all, about 11% of patients with a pelvic organ prolapse, okay, we do surgery. 88, 89% of them, we don't do surgeries. So don't think that if you have a prolapse, the only solution for the patient is surgery. In fact, most of the time, we don't do surgeries, okay? But when we decide to do surgery, okay, as a surgeon, as a robotic surgeon, we do a robotic approach for the pelvic organ prolapse, which, by the way, is the one that has the best long-term outcome. Okay, so there is a paper by Dr. Cooligan and his team that show a 90% success at 5 years. Okay, so if you compare that with any other approach, none of them has that 90%. Okay, so the robotic sacrocolpopexy, at least based on my experience and Dr. Cooligan paper, I think is the best approach. And
He's an amazing surgeon, and he gets
yeah,
amazing outcomes,
yeah,
and like yourself, right? So there's also that technique plus just the skill set, right? I mean
correct.
that's why it's so important.
And I think that and that is the reason we offer that. So having the ultrasound, so Dr. Cooligan showed that about 10% of his patients fail. So 90% success, 10% fail. Then when you read the paper, where are they failing? Where is this 10% failing? So they fail in the bladder and in the rectum. So what we call the anterior compartment or the posterior compartment. And therefore we look into that, and we have two papers that we describe pubocervical fascial reconstruction, a placation that we were able to find with the ultrasound. And we see, okay, if we can find where in anterior compartment where the injury is, and we reinforce this
right.
with a placation, can we improve outcome? And we have seen that certainly we improve about 5 to 7% outcome. So we can increase that 90 to 97 to 98% success. And we are extremely exciting about that. Of course, what we have is a short-term outcome. We need to continue following our patients long-term. But we were able to find those injuries on the anterior compartment based on the ultrasound. We'll see the scar, and then we fix during the robotic surgery. And
So I'll pause there. So I'll summarize it for the ladies. So that robotically speaking, uh, going in and and lifting up the vagina from the abdominal approach, and attaching that with mesh to the sacrum, and then going down below vaginally, and then addressing both a little bit of the drop bladder compartment, right? That maybe they had some trauma with the bladder, because you've already successfully elevated the woman's vagina, or they might have a little bit of some prolapse in the rectum, right at the entrance area, or between the entrance and then the apex, right? So that distance there. So now you're going to address some of those.
We do everything robotically. We
Okay.
don't do anything transvaginal. So because when we do the dissection between the bladder and the vagina, then we do everything robotically.
So you're
So the
just
plication, yes, the plication,
you'll go deeper. You'll go in
correct,
between the bladder and the patient's vagina
correct.
with the mesh, right? So you'll go up and address that area to kind
But
of.
in those patients that we see the injury during the vaginal birth, so we do an extra layer of reinforcement. You see what I mean?
Mhm.
Not only with the mesh, we'll say, okay, if we know with the mesh only 10% fail, what happens if we not only do the mesh, but we do another layer of reinforcement? And that's what we are proposing.
Okay, I love
You
it.
see?
Yeah, no, I
Then,
mean, that's important to take that technology and now elevate
correct.
the outcomes because now you have the data to say, hey,
Now,
I want to
for
be able to do
that
that.
80%, 88% that we don't do surgery, the question is, okay, Dr. Halda, what do you offer when you don't offer surgery? So,
That's right.
because, so we do pelvic floor muscle therapy. So we have physical therapists that work with us in the pelvic floor. We do biofeedback. We're trying to reinforce those muscles by taking the muscles to the gym. Is kind of an analogy that I give,
Mm-hmm.
As well, vaginal pessary is always an option. And this is one of those areas that I haven't seen any improvement in years. Just I was writing a paper the other day, and I was looking into the history of vaginal pessary, and there is evidence back in 1300 that were people putting things inside the vagina to prevent the prolapse, and they were using different materials and stuff like that. And there's even another one back in 600 that they were putting stuff in there. And so, how can we in 2023 continue offering vaginal pessary to our patients? It's hard for me to conceive. Okay, so we need to replace the pessary. We're still using them. It's basically it is something that we put inside the vagina, come in different shapes, and that will lift the bladder or the rectum without the need of a surgery. Of course, if you are sexually active, that not will be an option for you because it's an inconvenience. But if you are not sexually active, this is a good option. Okay. And but I'm looking, and our team are working really hard in trying to replace vaginal pessaries and offer something better for our patients because it's unacceptable that we have a robotic system, ultrasound, MRI, micro ultrasound, elastography, and we still
And
offering.
and here you go. You're gonna go home with this donut. I think we have one here at the studio. If
And it
the
would be good,
if the
Robert, if
ladies,
a question that I always get, if what is a vaginal pessary? So
right,
it would be good
pull
if
that up
you
there.
can show it to
I
them.
will
Yes.
right now. Here you go.
Yeah.
So one of these, right? So
One of those, it comes in different
all
shape,
different,
different
right? I
size.
mean,
Yeah.
I have an entire warehouse
Yeah.
full of
So
them of
yeah.
a cube,
So
a ring,
yeah.
and everyone has their name on it. So, when's the Davila uh, coming out? Because I think you're working on something.
Yeah, I working, and you know that I connect with you because you have a lot of experience creating companies, products. I have a lot of respect to you because of that.
Thank you.
And so we recently submitted the patent, so the patent is being reviewed. So we are working on the prototype. So, but the main goal that we have, the team, is to how can we replace these for something that patients can get in the office and they don't have to put something inside the vagina because this is unacceptable. And we are hoping that we can get these to our patients in the next 2 or 3 years. But it's still early. We're still doing some trials and tissue evaluation stuff like that. But when I have a little more something better that I can run it by you, I would love to have your your comments and maybe advice about what we're doing.
I can't wait. No, I'm excited. I always think of, you know, the, this space, and I feel like it's gotten more attention lately. I'm, happy to be a part of that, and have some of this technology that now can, align towards women's health. And I think more women are taking care of themselves, or they're not accepting the fact that these things happen, and they're saying, hey, I want to have a better quality of life. And so, what do you feel is the biggest game changer in your space in the last few years? What's some of the, let's say protocols, technology, or things that has really helped you, your practice, and your women?
I think I became a different surgeon when I started incorporating the pelvic floor ultrasound. I became a more global surgeon. As a urologist, sometimes we have a bias towards the bladder as the main organ that we deal with. But when you do the pelvic floor ultrasound, you see the totality of the pelvic floor and how big it is and how everything is interconnected. So I think that my personal game changer was when about 4 or 5 years ago, I started incorporating the pelvic floor ultrasound in my practice. Um, I recently have a conversation with the BK CEO, and we were talking about innovations, and so she asked me, what is innovation for you? And I say, well, that's a great question. I think that innovation is when you don't need something, but when you use it the first time, you cannot stop using it forever.
Right.
And I think that we need to look into that is, we need to innovate. Don't try to create something that people are asking for, because that means that already that field is crowded. That space is crowded. Try to create something that nobody is asking for, because that's truly when you are innovating there. Okay. And I think sometimes as a physician, we have the privilege to see what the patients complain, what the symptoms are, and what nobody is addressing with. And I think a lot of the female related symptoms are underestimated because nobody, really know how to handle this,
Right.
and I think that is what we have to keep in mind is listening to our patient. How can we translate that into creating better things? However, sometimes, the problem that we have as a physician sometimes is we don't have a training in how to create a product. We don't have a training of how to create a company. We don't have a training how to create something that can affect my patients, and that is sometimes what I think is missing in the medical education. So I hope that they usually start getting the education a little more broad into creating things in medicine, because I think that we have a unique opportunity, which is interviewing our patients' complaint every day.
No, absolutely, and that's a great place to pause, and for everyone to kind of think about, uh, you know, what are the needs of the patient, and we also have physicians that watch this also, and I think, you know, m- even more communication and more. I know you talk to a lot of other physicians out there about some of the technology and things that are working for you, and I think that the more people that pick up on that technology and incorporate it into their practice, then they'll help women in different parts of the country. But if you are in Florida, you can certainly book some time with Dr. Davila in Vero Beach. You have a beautiful office, right
Thank
there,
you.
off, I guess, what the intercoastal of, I don't know how they would phrase it there, but, just up the road from us on the east coast of Florida. And of course, I know you also cater to a lot of international patients that come and see you. If someone was going to fly in to see you, what's the closest airport for you?
Orlando is an hour 15 minutes from my office, so that would be the most convenient one.
Okay, there you go. So they can come in, drop their kids and husband at Disney World. But in fact, their husband probably might have to spend some time with you too. So they can. The good thing is that they could both come and see you and get a great checkup. So thanks for being on the program this morning, Dr. Davila. Always a pleasure to see you and to chat with you. Certainly look forward to the next time.
Thank you very much for the invitation. I'm looking forward to do this as many times as you ask me, and I'm looking forward to talk to you again, okay?
All right. Thank you so much. You have a
Take
great
care.
day. Bye-bye.